Hello, everyone, and welcome to this webinar, Decolonizing Nursing, What, Why, How, co-sponsored by Nursology.net and the Center for Nursing Philosophy at University of California, Irvine. I'm Marlaine Smith, kicking off this webinar as a member of the Nursology.net management team and chair of the American Academy of Nursing's expert panel on nursing theory-guided practice. The idea for this webinar began almost a year ago in our expert panel as we planned initiatives for the coming year. And Peggy Chinn, who needs no introduction, a panel member and national leader on diversity, equity, and inclusion and anti-racism initiatives, has written on decolonizing nursing theory. She's been the guiding force in planning and implementing this webinar. A special thank you to Miriam Bender, director of the Center for Nursing Philosophy, who enthusiastically agreed to co-sponsor this event along with the Nursology.net team. We're so grateful to all of you joining us today as we listen deeply to the perspectives from the 7 amazing nursing scholars on this panel. Peggy will now share information about the structure of the webinar. Peggy.
Great, thank you, Marlaine. We just want to be sure that everybody knows that this event is being recorded, and the URL link will be to the recording will be sent to everyone after the meeting is over. We plan on having 20 minutes of time at the end of the panel for a Q&A session. So please feel free to write your questions into the Q&A while people are presenting, not in the chat at any time. You can use the chat to just communicate with everybody who's in the, to say hi, to post any resources that you want to add, things like that. But anything that you have that you want to be directed to the panelists, put it in the Q&A, and Marlaine and I will collate the questions to present to the panel during our final 20-minute Q&A session. So it gives me great pleasure to introduce Miriam Bender, who is Associate Professor at the University of California, Irvine's Sue and Bill Gross School of Nursing. And Dr. Bender is serving as the moderator for today's panel. As a nurse philosopher, Miriam uses a process philosophy lens to conceive flux and emergence rather than stasis and unity as fundamental nursing foci of inquiry, and proposes modes of inquiry with the potential to mobilize flux emergence to achieve disciplinary goals of health and wellness for people, families, and communities. So indeed, it's an honor to me to be welcoming Dr. Miriam Bender as the moderator of this discussion, which we anticipate will mobilize flux emergence of new decolonized perspectives on nursing and nursing knowledge. Miriam.
Thank you, Peggy. It's just an honor to be here with this group of people today, which I would love to introduce. So as I introduce the person, if they could just kind of wave their hands so the audience knows who they are. And I'm introducing them in the order that they will be presenting their work. So we will start with Dr. Bourque Bearskin, who is Associate Professor at Thompson Rivers University in British Columbia, Canada. Also the first inaugural BC Research Chair in Indigenous Health in nursing, and will introduce the concepts of decolonization and truth and reconciliation to us. Lisa, could you kind of wave and let us know who you are? Wonderful. And then she will be followed by Dr. Lucinda Canty, who is assistant professor of nursing at the University of St. Joseph. She's a certified nurse-midwife and host of the Overdue Reckoning on Racism in Nursing initiative. She will speak about her scholarship on perinatal morbidity and mortality of Black women and its implications. And I saw her wave. She'll be followed by Dr. Jennifer Wu, an assistant professor at Texas Women's University. She will speak about the importance of highlighting BIPOC nursing heroes in nursing midwifery education as a means of decolonizing nursing. And Jennifer will be followed by Dr. Barbara Hatcher, who is principal at Hatcher Dubois Odrick Group in the United States. And she will speak about vaccine hesitancy and the experiences that give rise to it and other issues affecting Black and Brown people. Dr. Hatcher will be followed by Dr. Lucy Makendawiri Balmu, a professor at the University of Wisconsin-Milwaukee in the United States. And she will speak about the importance of decolonizing nursing academia as a way of enhancing the success of BIPOC students. She will be followed by Dr. excuse me, Dr. Daniel Suarez Baquero, a Latino nurse from Colombia and a postdoctoral fellow at the University of California, San Francisco in the United States, who will speak about a scholarship related to discounting the ways of people around the world and the concepts and perspectives embedded in Spanish and Latin America. Excuse me. And last but certainly not least, we will have Bukola Salami as Associate Professor at the University of Alberta in Canada. I think she's the northernmost person here, latitude-wide, who will speak about her work with Black youth from a decolonization and critical lens. So a stellar, amazing lineup today. So I would like to have Lisa begin our event. And if you'd like to share your slides, go ahead.
Can you just see my slides?
We see slides and note and the next slide. And now we just see your slide.
Okay. Danse, Knas Kumtin, Kuta, Kistiga, Kwapamatsuin, Lisa Bourque Bearskin from Beaver Lake Cree Nation. And I want to thank our esteemed colleagues who have joined us here today and all my colleagues on the panel for inviting me to join the conversation on decolonization, what now, what, how, and why. And so to begin, to acknowledge all of the original peoples known as the traditional right holders and custodians upon which we live. We want to honor and respect all those historical relationships with the land that continues today. We want to hold up our hands to respect the knowledge holders and elders and the children of the past, the present, and the future, for they hold the memories and the traditions and cultures and the hopes of Indigenous peoples across Turtle Island. And I want to just quickly identify where I originate from, Treaty 6, which is in northern and Bukola. It's in Edmonton, Alberta, from Beaver Lake Cree Nation. And I want to acknowledge my grandmother, Miriam Bender, and my uncle, Gilbert, and my children who have really helped me to journey through this work. And I also want to pay special tribute to the traditional and unceded and occupied traditional territories of Tecumseh to Shwetma. And you'll see here on the map in the red here, the red Shwetmik sheen is their language, and in the bigger scope you'll see the picture of the globe, and we are located sort of centrally within interior British Columbia. And this is a new book that's just come out on the Shwetmak people, so I try to acknowledge and found all that. So I have the privilege and honor to introduce what is decolonization, to talk about a bit about truth and reconciliation, calls to action, what you can do and what we can do together. And looking at this picture, we see where we've started historically, which we haven't been informed of in our nursing education systems, to where we are now. And I have to acknowledge and honor these three students, they're current students in our undergraduate program, who are from within this nation. And so what is colonization? It's, in a basic sense, it's a process that can be defined of establishing a foreign control over targeted territories of people for the purposes of cultivation, often through establishing colonies and possibly by settling themselves. It's referred to a large-scale movement in which takes place under the protection of colonial structures, in which some term colonial colonialism. The impact of colonization is the systems, as you'll see here, I found this figure very enticing. Dr. Rupa Mariah really highlights the impact of colonization. She delivered this presentation at the bioengineer conference and really highlighted the importance of the impact of systems domination. And you look at the end impact here is trauma and ultimately inflammation. And we can see that happening highly in our numbers of chronic disease, cancer, and so she referred to this as the era of inflammation and the impact of social stressors. So it's really about the systems of supremacies expressed in many ways and outcomes. And so when we ask about colonization, we have to think about what does decolonization mean. So decolonization, it refers to that process of deconstructing those colonial ideologies and superiority of white privilege and Western thought. On the one hand, decolonization involves a dismantling of structures that perpetuate the status quo, and on the other hand, it involves the valuing of revitalizing Indigenous knowledge. And here and within this territory, Arthur Manuel is a United Declarations leader, and this is his traditional territory. He's been well known all across the country in talking about what decolonization is. And at the one end, it's really about the return of the land. And so when we think about that, what does that mean? It's hard to really wrap your head around what that actually means. So helping us to rethink our questioning for the purposes of understanding, grounded in United Declarations of Indigenous rights of people. And so the questions that I kind of think about is, what are those contributing factors that support, sustain oppression? And what is your truth, and what will you do to reconcile this truth? And how do we achieve epistemic justice, and how do we avoid epistemic appropriation, are some of the key questions that we have to really unpack. So understanding how does systemic racism work? We have to go back to the foundation of this country, Canada. It is deeply rooted. We see it still in present day forms of what some of us would know as the Indian Act. It's often the most difficult to recognize and counter, particularly when it's perpetuated by institutions and governments who do not view themselves as racist. So when we present in a range of social contexts, this form of racism reinforces the disadvantaged and the already experienced by some members of our communities. And hence the Truth and Reconciliation was mandated by the Government of Canada in 2018, which forced the government to really take a deep dive into the impact that it was having on people across the country. And specifically here within BC, an independent review specifically understanding Indigenous specific racism really highlighted and brought to attention some of the work that we're facing here in British Columbia. And it really highlights the need for anti-racism as identifying the challenges and identifying ways to eliminate this, and really opening up discourses and courageous conversations on the values and structures and policies and programs that continue to guide and function within this notion of reconciliation, decolonization, and colonization. And so why truth? The truth-telling and reconciliation process is part of that overall holistic and comprehensive response to the Indian residential school legacy. It is a sincere indication of the acknowledgement of these injustices experienced by Indigenous peoples and the need for continued healing. This is a profound commitment for renewed relationships embedded in mutual authentic partnerships. And so revealing recently, for some of you within Canada will have heard the revealing truths of Tecumseh Sretmac with the discovery of the 250 unmarked graves. And so I do this work, to honor my own lived experience as a survivor, as this child of the residential school movement, as a child of the 60s scoop, to sort of really work on decolonizations to reclaim my own understanding of Indigenous knowledge and those relationships that I have. And so it's important that we all remember, as of July 21st, 2021, there have been 1,500 graves located. And think about that number, because that's only 7 out of the 139 schools so far. So I think it really presents an opportunity for us to really go back and really ask questions. And so for me, when I started to do this, I really thought about those original Indigenous nursing pioneers, and why did I never get education on who Mary Seacole was, or Edith Montour, or Mary Mahoney, all instrumental pioneers within the same vein as Florence Nightingale. And so really starting to unpack our own nursing history. And, you know, questions that I ask myself is, one of our famous leaders here in Canada is Jean Goodwill Cuthand, who in 1974 was the first Indigenous nurse in a political position where she was advisor to the Minister of Health. And so it wasn't even until early 1990s that we even started hearing in nursing education about the Canadian Indigenous Nursing Association, and the importance of decolonization is not just, you know, a lot of you will remember if the pleas to sparing her life and to calling for respectful treatment at the end of her life, Joyce Echequan. I can't speak enough to the importance that we play as healthcare providers, that we were all witnessed her cries for help that one night. And then when we think about Brian Sinclair, 34 hours in emergency, videotaped numerous people calling or approaching him within the waiting room, but never being assessed for care properly. So it really reinforces the healthcare needs of our underrepresented population. And so the Truth and Reconciliation outlined these 94 calls to action. And I can't see where my time is.
We're almost out of time.
Okay. Yeah, so one thing I just wanted to highlight, that even though we've had all this movement within Canada on the Truth and Reconciliation, you can see here by the yellow markers, out of the 94 calls to action, there's only been those 9 calls. In yellow, they have been addressed. So considering the time we've faced, these are some of the reasons why the lack of action. You know, it's been the exclusion of Indigenous people. It's been this ongoing legacy. The impact of residential school is still very much real today. It's deep-rooted in paternalistic attitudes. And number one right now, the challenge is insufficient resources. Everybody wants us to do this work, but there is hardly any money for us. So this history is not our fault collectively, but it is our responsibility to do something to move forward in a good way, to honor the intentions of a justice, equity, diversity, inclusion, and recognize the dynamics of ongoing and intergenerational transformation for decolonization to really happen across the country. So we have an active role to play, working against oppression toward equality and addressing inequities to elevate the historically and systematically underserved groups. We do know education is the key, and one of the favorite statements that I have is, you know, when we try to implement trauma-specific clinical practices without first implementing trauma-informed organizational cultural change, it's like throwing seeds on dry land. And with that, I would like to thank you, and I will turn it over to Lucinda now.
Thank you so much, Lisa.
Thank you. Lisa, that was brilliant, brilliant. So my approach to decolonizing nursing is through the lens of Black maternal health. My research interests are the experience of Black women during childbirth, the experience of severe maternal morbidity, and also just my research interest is also addressing racism in nursing and midwifery. When I started my dissertation research, the purpose was to understand why Black women are more likely to die during childbirth. I want to know, why are we dying? But this research led me on a journey to understanding racism. As a Black nurse, I knew that racism existed, but I didn't always know how to name it. I didn't know how to understand it. Sometimes I didn't even see it, but it still had an impact on me. Researching the experience of Black mothers provided me with a clear understanding. I have a better understanding how racism is in nursing education, how it's in nursing research, nursing leadership, all the areas that influence patient care, whether it's at the bedside or in the community. When I initially went to the literature, I found very little nursing research that addressed Black maternal health. I found a few studies that looked at Black women and their experience in childbirth, nothing on Black women who suffer severe pregnancy-related complications. And what I found in this literature search were predominantly epidemiological studies that consider like what placed people at risk for poor maternal health outcomes, but I didn't find anything that really considered the experience of being racialized, that it places on Black women and the harm that it causes. These epidemiological studies focus on risk factors, but not on what the experience was to be a Black woman in America. They looked at race, low socioeconomic status. They looked at being uninsured. I'm sorry, I'm gonna stop the slides. Because I really wanna get my message across. They looked at all the factors that they looked at, let me just back up a minute. These studies focused on the risk factors. They looked at race, low socioeconomic status, being uninsured, residing in poor neighborhoods, being unmarried, late entry to prenatal care, or no prenatal care at all. So that's what they were looking at. But when you focus on the experience of race, you don't look at the other complex issues that are related to being a Black woman, being a Black mother. So when someone reads this literature, they can often mistakenly interpret race through an unexamined biased lens. And as a result, frequently blame Black mothers for their own severe preventable complications. The focus was on race. Race is a social construct. There is no genetic predisposition that places Black women at risk for dying during childbirth. I'm gonna say that one more time. There's no genetic predisposition that places Black women at risk for dying during childbirth. There are a few enlightened scholars, only a few of them nurses. We gotta do better in that. I'm gonna ask you all for help in examining this. But there are a few that understand that racism, chronic stress, racism has epigenetic consequences for maternal and infant health. One of the most critical things that I learned from my research is that in the United States, if you are a Black woman, you can start prenatal care early, you can receive adequate prenatal care, you can have insurance, you can have numerous degrees, be financially well off, you could even be Serena Williams, and you can still die or come close to dying from a pregnancy-related cause. To decolonize nursing, we have to understand our history so that we understand how racism is influencing nursing today. We need to go back to a time when Black women felt safe and empowered during childbirth. Historically, in the Black community, we've always valued and treasured childbirth. Birth has always been a way to empower us, even during slavery. If you can imagine that woman, that Black woman during birth, that was her only moment that she had some power and control. She didn't know what was gonna happen after, but at that moment, she had control and she felt empowered. And it was regardless of what was happening around them. The Black midwives that provided care to these women provided care with respect and dignity. Even with limited resources, there was always a sense of community. An elimination of the traditional Black midwife, the movement from Black births, going from the home to the hospital, and that going to the hospital, births were supposed to be safer for Black women, but it actually took away their power and their voice, their sense of safety, even just their sense of autonomy. Black women are not even believed to understand their own bodies. If I say I'm in pain, I'm in pain. If I say something doesn't feel right, then something is wrong. And as nurses, we have to give that power back to the women. We're right in the middle, we're right in the core of this. There's no one who can provide care without a nurse being there. They need us. So it doesn't matter if you're a nursing student, a nurse educator, a nurse researcher, if you're in a leadership role, you can do something. We can figure this out. We can be creative. Start by looking at this panel. We're all nursing scholars of color. We exist, and we're not alone. There are a lot of us out there. So stop saying that we don't exist. And you can use our research to educate your students, to advise nursing students of color, especially those who are conducting research. If you're working with a student of color, if she's looking at race, if she's looking at racism, if she's trying to figure out other issues in nursing, you have to be able to be a support to them. Instead of breaking them down, you have to lift them up. If you're not educated and helping them, find someone who can. Find someone who can give them that support. But use our research, it's out there. Use our research if you're developing your research proposal. If you're developing a research team, if you're building that up, you could use our research to help guide you. We're developing nursing knowledge. We're contributing to nursing science. We're decolonizing nursing. So we're here. And I just feel that we have such a strong, important role to play as nurses. I met Miss Frankie Manning. She's been in nursing for over 60 years. She told me when she started practicing, they had colored wards. I always thought that was just something in the movies, but they really had colored wards. But she told me how one of the worst experiences she had was working in maternity nursing, how badly the Black women were treated, how they had their babies on infectious disease units. What struck me the most, though, is what she was talking about, the harm caused. It's still happening. It's still happening today. So I'm just asking all of us as nurses to think about what we can do, because it starts where we're at. It doesn't matter where you're in your journey to be anti-racist. You can still do something. So we have to be able to do this. I'm going to end with a poem that I wrote called This Land We Call America. I sit in the complexities of life, wondering if I will ever feel safe as a Black woman on this land we call America. You call the land of the free, the home of the brave, free, brave. I wish those words could mean the same thing to me and the sons and daughters I will birth on this land my ancestors built, this land called America, built on the backs of Black bodies, a forgotten history of birth, pain, and suffering, but also of resilience and determination. It's because of Black woman that I'm here. I'm inflicted with 400 years of harm, still affecting the treatment of my womb. A Black body I'm still trying to control in a healthcare system where I should feel safe, but we all know I may not survive. You act like you don't see me. You pretend that you don't hear me. You turn your head away from the treatment you know is killing me, afraid to look in my eyes, afraid I'm going to tell you the truth. You need to know who I am to understand why I fight just to safely give birth on this land we call America. Thank you.
Thank you, Dr. Canty, for that amazing talk. We will move right ahead and please introduce Dr. Jennifer Wu. Would you like to turn on your camera?
Sorry, Dr. Canty, that just sent chills down my spine. It's hard to follow that. So I'm Dr. Jennifer Wu, and I work at Texas Women's University. I'm just thankful for living on the ancestral land of Wichita, Comanche, and Caddo tribes, living here in the Dallas-Fort Worth area. I'm going to talk a little bit about the history of nursing, and when we talk about decolonization of nursing, we must take an honest look in the mirror on the heroes of nursing that are amplified and focused on in our curriculums. Florence Nightingale is the epitome of what nurses learn about when being taught the history of nursing. While I would never want to belittle or tear down the amazing work she has done for the profession of nursing, we also know, based on some of her writings and historians, that she espoused colonialistic thoughts and overtones. Mary Seacole also worked in the same era as Nightingale, yet somehow her contributions are not as widely promoted and spoken of. It is not by coincidence that she's not included in the annals of famous nurses in the history of our profession. She integrated herbal medicines and learned about caring for the sick from her Jamaican mother. She attempted to join Florence Nightingale's team during the Crimean War, but was rejected because of the color of her skin. She, by her own volition and by her own expense, went to the front lines of the war and established what's been known as the British Hotel, and also referred to as Mrs. Seacole's Hut, where she provided a restaurant for British soldiers and officers, as well as turned the second floor of that facility into a makeshift hospital. What I found really interesting in just researching about it is there are many nurse scholars that challenge Mary Seacole's contribution to nursing and are resentful of the fact that she's compared with Nightingale, using evidence that she was not, quote unquote, a real nurse because she never went through official schooling, which she was denied admission to because of her color. The fact that she volunteered her time and efforts to serve on the battlefield without a title speaks to her commitment to humanity. In addition, this nurse, researcher, historian speaks to the fact that there just isn't as much published about her work in referring to Seacole as a nurse when compared to Nightingale, which speaks less to the validity of what she did and more to the times in which she lived. Just speaking to a quote written by Lady Alicia Blackwood, and it was a book published in 1881 referring to Mary Seacole. She had, during the time of battle and in the time of fearful distress, personally spared no pains and no exertion to visit the field of woe and minister with her own hands such things as she could comfort or alleviate the sufferings of those around her, freely giving to such as could not pay and to many whose eyes were closing in death, from whom payment could never be expected. And then moving along in the civil rights movement and the Civil War, recognizing Sojourner Truth, she's more often known in history as her role as an abolitionist and women's rights advocate, but she also served on the front lines as a nurse during the Civil War, caring for her fellow man, fleeing the South and migrating to the North, learning nursing skills and caring for the wounded at Freeman's Hospital in Washington, and was recognized by President Abraham Lincoln for her work. And recognizing Susie King Taylor, she was born a slave in 1848 in Savannah, Georgia, but taught herself how to read and served on the front lines during the Civil War as a nurse for the Union Army. She was the only African-American woman to publish a memoir of her wartime experiences, and specifically in her role as a nurse on the front lines. She published Reminiscences of My Life in Camp with the 33rd United States Colored Troops. She was also well documented in Dr. Mary Elizabeth Carnegie's book, The Path We Tread, as she served her people. One thing I just wanted to share, I was preparing for this and preparing for this presentation and showing the slides to one of my undergrad students, and she actually started crying. She was just floored by the fact that all of these, she knew who Sojourner Truth was, but she didn't know that she worked as a nurse on the front lines. I think when we think about decolonization of nurses, we need to recognize the importance of representation and really highlighting the voices of those who've come before, and so that our students can really see that, can see those heroes and say to themselves, I can do that, and I can make a difference. And so I want to highlight Mary Elizabeth Lancaster Carnegie. She was born in 1916 in Baltimore, Maryland, during one of the most turbulent times for African Americans. And I want to actually quote from Dr. Geiger and Strickland, who wrote an amazing tribute to her life in nursing research that was published in 2008 when she passed away. Dr. Carnegie went on to distinguish herself as a nursing educator, a nurse leader, and a major civil rights activist by breaking down every racial barrier in nursing. Because of Dr. Carnegie, nurses of color who had not been wholly recognized for their contributions to nursing were able to leave an indelible mark on this profession. When we speak about her breaking every barrier, she became the first African-American nurse to be the editor of American Journal of Nursing, Nursing Research. She became the first African-American nurse to serve as the president of the American Academy of Nursing. And I think this quote on this slide just really represents and epitomizes what she did for our profession. And I just wanted to highlight, Dr. Canty wrote this amazing master's thesis, historically documenting the Tuskegee Midwifery Institute. And this institute was established in 1946 because of the high infant and maternal mortality rate occurring in Black women in the South. What occurred to me when preparing this, I'm surprised even that they established this and recognizing the need and the importance of training Black nurses to be midwives and recognizing that there were community midwifery was happening in these communities because women couldn't get care in hospitals. And speaking to Dr. Canty's, that there were hospitals where people of color could not get care, and recognizing our role that we cannot have that two-tiered health system in our country. And Helen Sullivan Miller was one of the first midwives that got trained in the Tuskegee Midwifery Institute, and she went on to become the dean of the North Carolina Central University and served to do amazing work. So when we think about even comparing the disparities from 1935 to the present day, we see we haven't made much of a dent. The disparity is still huge. So it calls us as nurses to challenge ourselves to think beyond the box of what we know is true. And, for myself, being a nurse midwife and doing health disparities research, recognizing the importance that we do need to train more Black midwives. And even in our profession, only 10% of midwives in our country are Black women. And we need to make a difference in if we're going to make a dent on this disparity. Thank you so much.
Thank you, Dr. Wu. That was very powerful. And if everybody wants to look in the chat box, I think everybody can see the power of these presentations being expressed. Dr. Wu will be followed by Dr. Hatcher. Would you like to share your screen or open up your video for us?
Most certainly. Hello all. Good evening. One of the biggest hurdles to vaccination is hesitancy. The World Health Organization defines hesitancy as the delay in acceptance or refusal of vaccines despite availability. In communities of color, hesitancy is often a direct consequence of the medical system's mistreatment. The culture of medical exploitation, abuse, and neglect of people of color, and in particular, Black Americans, is best exemplified by the Tuskegee syphilis study, which for 40 years kept some 400 Black men with syphilis in rural Alabama ignorant of their diagnosis and denied them adequate treatment. There are other historical incidents compounding the mistrust in communities of color. However, this is not a problem relegated to the past, because communities of color are still treated poorly today. Add to the mix the murder of George Floyd during the early part of the pandemic quarantine that made it clear that Black lives do not always matter. In addition to the historical and current issues that relate to trust, social media and 24-hour TV has added to the misinformation promulgated by the anti-vaccine movement. COVID-19 disproportionately affects the world's marginalized communities, including here in the US, where communities of Black, Indigenous, and people of color are still less likely to be tested and vaccinated and experience more hospitalizations, disabilities, and death. Can I have the first slide? These facts are supported by various published research. The Kaiser Family Foundation's COVID monitoring data demonstrate that Black and Hispanic people are less likely than the white counterparts to have received a vaccine, leaving them at increased risk, particularly as the highly transmissible COVID-19 Delta variant continues to spread like wildfire. As of September 8th, 2021, CDC reported that 59% of the peoples whose race and ethnicity is known and who also received at least one dose of the vaccine, nearly 2/3 were white, 10% were Black, 17% were Hispanic, 6% were Asian, 1% were American Indians or Alaska Natives, and less than 1% were Native Hawaiians or other Pacific Islanders. Further, the Kaiser Family Foundation monitor data show that the share of vaccines received by Black people is smaller than their share of deaths. For example, in the District of Columbia, Black people have received 44% of the vaccinations, while they make up 56% of the cases, 71% of the deaths, and 46% of the total population. In California, 31% of the vaccinations have gone to Hispanic people, while they account for 61% of the cases, 47% of the deaths, and 40% of the total population in the state. Next chart, please. The Kaiser, I don't know why I keep on saying Kellogg, the Kaiser Family Foundation analysis of the unvaccinated population finds two distinct groups. Those who are open to getting a vaccine or wait and see, as they term it, and those who say they will not get the COVID-19 vaccine. The July 2021 Kaiser Family Foundation Vaccine Monitor found the key demographic differences between the wait and see and the definitely not groups center on racial/ethnic and religious identities and political partisanship. 4 in 10 of those in the wait and see group are people of color, while the most vaccine resistant group, those who say they will definitely not get the COVID-19 vaccine, is overwhelmingly made up of white adults who are partisan Republicans or Republican leaning and evangelicals. What is important for this discussion today is that unvaccinated groups among the communities of color are younger and less educated. Can I get the next slide? As the data shows in this slide, this data published by Lawrenson determined that Black and Hispanic populations make up a significant proportion of the hesitant groups by race or ethnicity. So if you note the last 2 bars, the orange and red bars, you will see the high number of African Americans and Hispanics in those groups. Other groups are not as predominant. These facts are consistent with my experience with community outreach related to COVID-19 in the District of Columbia, where younger Black males demonstrate increased hesitancy. Recent reports by various groups, such as the NAACP, note that vaccines are reaching larger shares of the Black, Indigenous, and people of color. However, we need to better understand and address hesitancy, as well as the structural barriers such as access. Medicine has broken the trust with the communities of color and must earn it back. Those who express vaccine hesitancy also show high levels of overall mistrust, concern about potential harm and side effects, and lack of confidence in vaccine effectiveness and safety. The lack of trust in vaccine development, the vaccine development and approval process explain most of this hesitancy. Mistrust of the government's and healthcare's motives and transparency around COVID-19, as well as the beliefs about systemic racism, continued discrimination, and mistreatment add to the mistrust. Further, mistrust is seen in communities of color as an understandable, rational, and self-protective reaction. To address vaccine hesitancy, you can turn off the slide so people can at least see me, I guess. To address vaccine hesitancy, the World Health Organization and other European entities have developed the 5C model. The model shows that vaccine hesitancy occurs when any of the 5 C's are compromised. So let's review the 5 C's. The first is confidence. There must be confidence in vaccine acceptability, safety, efficacy, and importance. There's also the need to monitor vaccine complacency. This exists when the perceived risk of vaccine preventable diseases are low and vaccination is not deemed a necessary preventive action. Vaccine convenience is a significant factor affected by physical availability, affordability, willingness to pay, geographic accessibility, the ability to understand, including language and health literacy, and the cultural appeal and real and/or perceived quality of immunization services. The fourth C involves effective communication aimed at dispelling misinformation. Given the infodemic we are experiencing in the US, the use of trusted individuals, proximal leaders, and community engagement is key. Finally, putting it all in context is the fifth C. We know factors such as ethnicity, occupation, and socioeconomic status are often overlooked in vaccine initiatives. Initiatives must acknowledge more than the individual behavior and include recognition of powerful structural factors such as systemic racism and access barriers. There is research that has looked at how to tackle hesitancy using the 5 C's. I do have a chart that I could share at another time or put in the question and answer in the box, but I'll bring up several points real quickly before I run out of time. COVID-19 messaging should first acknowledge systemic racism as a justifiable reason for mistrust before providing information about the vaccine. Public health messages and communication strategies to address vaccine hesitancy should be tailored through authentic community engagement. We must help Black, Indigenous, and people of color to better understand that the risk of contracting COVID-19 may be up to 10 times higher and worse than experiencing a significant side effect from the vaccine. In 1903, one of my ancestors, W.E.B. Du Bois, a noted American sociologist, historian, civil rights activist, and a founder of the NAACP, stated that the problem of the 20th century is the color line. Du Bois stated this with the hope for the future and the belief that this problem would be eliminated in due time. Here we are in the 21st century and 118 years later, and reports continue to document that marginalized communities are negatively impacted by disease and death from many causes, including COVID-19. In summary, we need integrated, decolonized approaches advanced by trusted and proximal individuals and institutions that address the complex interdependence between histories of systemic racism with health, economic development, governance, and human rights. Most importantly, is about how we treat people. Health systems, leaders, educators, researchers, policymakers, and policy institutes must examine and reform their mission and values. All peoples must be valued and individuals' unique lived experiences respected. As health professionals, we must demonstrate cultural humility in our interactions and considerations of others. We must place a high priority on conducting research that leads our systems to equity. Only by building policies, systems, and practices that account for implicit bias and systemic inequities will communities of color prosper and mistrust begin to dissipate. Thank you.
Thank you so much, Dr. Hatcher, for that. That was amazing. And I would like to go ahead and ask Dr. Makandari Valmu to share her screen and her slides. Oh, no slides, just her screen.
Good evening, everyone. I would like to start by acknowledging that in Milwaukee, we are on traditional Potawatomi, Ho-Chunk, and Menominee homeland along the southwest shores of Michigami, North America's largest systems of freshwater lakes, where the Milwaukee, Menominee, and Kinnickinnick rivers meet, and the people of Wisconsin's sovereign Anishinaabe, Ho-Chunk, Menominee, Oneida, and Mohican nations remain present. I promised myself that I would not express any appreciation or gratitude or even apologize for taking up space here today. I grew up in a small African country called Malawi in Southeast Africa, where that was colonized by the British. And so where I'm from, people apologize all the time for everything and express gratitude, even when they are experiencing oppression. And so taking that into account, that oftentimes as Black, Indigenous, and people of color, even when lands are being taken away, when we are told that we are less than everybody else, we still apologize or express gratitude. I'm committed to not expressing gratitude today or apologizing for taking up space that should be taken every single day, taking into account the injustices that have been discussed, whether it's vaccine hesitancy as a result of mistrust in a system, a healthcare system that centers whiteness, and a healthcare system that has engaged in harm towards Black, Indigenous, and people of color for centuries. And so taking up space every day, all the time, is important so that these injustices are discussed and so that we can work together to move forward. When I walk into a room and into a space as a Black woman, here in Wisconsin or wherever I might find myself, and it's a predominantly white space, I'm sure perhaps my colleagues are different from me. I do get the jitters and I feel uncomfortable, and I feel as though I'm representing the entire African diaspora. And so if I mess up, it means that the entire population that identifies as Black, regardless of where they are, is also under a microscope, or they are somehow under disdain because of how I have conducted myself. And yet in that kind of environment, in nursing academia, for example, or in academia more broadly, we expect our young people who identify as Black, as Indigenous, as students of color, we expect them to learn about a profession that is complex and that involves caring, which is both an art as well as a science. And we expect them to succeed in that kind of environment. We expect them to navigate that kind of environment where whiteness is constantly centered, where the curricula is focused on very Eurocentric ideologies. Examples that are given in class are centered on whiteness. And we expect students who often are the only Black, Indigenous, Hispanic, Latinx student in that particular environment. During these past couple of years, starting last year, we know we've had a pandemic. We have had injustices that have been recognized, shown on social media, the murder of George Floyd, and other injustices that have happened, some even in the state of Wisconsin. All of these have contextualized the lives of our students. And again, every day our students are supposed to be in class and pretend that these activities are not happening. Dr. Hatcher spoke about vaccine hesitancy. We have seen, particularly at the beginning of the pandemic, we saw Black, Brown, Indigenous people of color dying at higher rates than disproportionately. And yet we expected our students to continue going to class when their communities were disproportionately affected. So when we think about even in recent times, just this past week, these past couple of weeks, we have been witnessing the media support of Gabby Petitio, who died at the hands of her boyfriend or fiance, in the knowledge that hundreds of Indigenous peoples in the same area where she went missing in Wyoming, hundreds of Indigenous peoples, including young girls, to the tune of about 700, have gone missing in Wyoming alone within the last decade. And yet, we don't even know their names. Their experiences have not garnered any attention in social media. And so again, our students are supposed to navigate this kind of environment where every day they are told that they are less than, that their lives are of less value. And again, whiteness is centered. And so it's within this context that I'd like to suggest that our pedagogical approach to education of nursing students has got to change, that we need to unlearn racist ideologies. Recently, Ibram Kendi came to our campus about a couple of days ago, and he said that oftentimes, we blame people who are underrepresented within the academic environment, within institutions. We blame them because they're not represented. And so they're not even present, but we are blaming them for not being present within academic institutions. And so it's important to really unlearn those kinds of racist ideologies. Dr. Canty spoke to how we blame Black women for their own mortality as women during childbirth. We blame them for infant mortality. And these are part of a racist ideology, again, that upholds whiteness and blames people who have been oppressed over centuries for lack of representation in particular spaces. And so these kinds of racist ideologies have to be unlearned, and we have to continue unlearning these racist ideologies. Some ways in which nursing academia is addressing some of the challenges that we face with regards to the underrepresentation of BIPOC students within nursing academia is through holistic admission, and that is to be commended. But we need to also address the climate in which nursing students come to class every day. In our state, for example, in the city of Milwaukee, we're a very segregated, one of the most segregated metropolitan areas in the country. And so many white students are coming from homogeneous environments where they have never interacted in a meaningful way with a Black or Indigenous, Hispanic, Latinx person of color. And they're having to learn how to do that. And so their learning is done on the backs of their colleagues who identify as Black and Indigenous, and they are students of color, and they're ethnic minorities in a predominantly white space. And so they have to hear comments that their colleagues are making. Sometimes they have to hear comments that faculty are making. And so it's really important that, you know, we think about that kind of climate and how we can promote success, and how the success of white students should not be on the backs of our ethnic minority students. We need to stop engaging in white fragility. And so when nurses of color within the academic space point out racism, and it's important to point out when there is racism and not say, well, it's discrimination or try to tone it down. It's important that we hear one another and that we stop engaging in white fragility and call a spade and not a big spoon. So, you know, that is something that we need to continue to do. We also need to engage in being anti-racist. So it's either we are anti-racist or we are upholding structures and systems that continue to oppress our students, continue to oppress people of color, because much of the vaccine hesitancy that we see is because when people go for a vaccination, they continue to see systems of oppression and they engage with people, they see nobody who looks like them. So I agree with Dr. Canty, we are here, but many times within the healthcare system, we are not present, and we're not present because of systems of oppression. And so it's very cyclical, but we need to make sure that you know, we support our students so that they can be successful and they can go into the workforce and be representative, so that our communities, when they go to access care, that they, you know, that they can see themselves represented and they can build more trusting relationships within the structures that we have. I will conclude by saying, by quoting Audre Lorde, who said that the master's tools will never dismantle the master's house. And so we cannot continue to use the same strategies that we have been using in the past to deconstruct a system and to dismantle a system of oppression that has been there for centuries. And so it's important to really think about the ideologies that we embrace, how we can unlearn, again, racist ideologies, and how we can develop different kinds of structures, different kinds of environments that are more nurturing to our students, because again, the academic environment was not made to be nurturing because it was not meant for BIPOC peoples. And so how can we continue to do that? And again, I will not say thank you, I will just say good evening.
I will say thank you. Thank you for that amazing talk. I just want to do a quick announcement to everybody. We still have 2 more speakers. We realize we might finish just on time. We will be here for your questions after, even if the time frame ends. With having said that, I would love to ask Dr. Suarez Baquero to come to the screen to share his video.
Yes, hello, can you hear me?
Yes.
Okay, I would like to begin by acknowledging the land in which I'm talking today. I honor this ancestral and unceded territory of the Humanos and Tocawa nations, and I honor and respect all those whose historical relationship with the land continue to this day. Well, first, before getting to the colonial, it is essential to state me as a person, so you can know a little more about my path. I was born in Colombia, where, like in most of Latin American history, was flooded us in the remarking of how Spanish, Italian, French, etc. we are, in a detriment of the indigenous, Afros, and mestizos, because part of the colonization is to hide the stories and histories. The same happens in our discipline, hiding and minimizing the different, the others. I have Latin American and Native American ancestry. My childhood home was Bogota, Colombia. I studied my BSN and MSN in the Universidad Nacional de Colombia. I was the first male nurse in labor and rooms across different hospitals in my country. I recently graduated from my PhD in nursing at UT Austin, and currently I'm a postdoctoral fellow in the Actions Program at UCSF. I'm a nursing scientist, nursologist, and nursing theories in progress. Despite my multicultural childhood and young adult experience with homophobia and aporophobia, it was not until my path through UT Austin that I began to understand the actual experience of racism, xenophobia, and the colonial center that dominated my childhood, young adulthood, my discipline, and my doctoral path. These years have been a long journey to self-awareness and community that made it possible through passion and courage to speak to you today. My own story has allowed me to reread the story we have been told, because upon my arrival into the US, I became an immigrant. I don't know for how long, since in the case of most immigrants, only the decision of the powerful about their future will tell. Being an immigrant allows one to have another look at where one is, but also about other places where one goes. And so, in Colombia, living certain types of discrimination where I got abroad, I found other types of discrimination and racism that I share with many more people. Therefore, I will share during these minutes some of my own experiences that have a lot to do with colonization, racism, and exclusion. I remember like it was yesterday when I started to share my thoughts about nursing, about my Latin American nursing heritage, and the constant rejection and denial about the canons and postulates that for years I had been studying and believing were universal. My first encounter with this experience was when I stated that I wanted to study cuidado, that in that time I mistranslated it literally as care and caring. And the answer I received was, that is too old, what is your biomarker? Such a question tore apart all my world. How would it be outdated to study the core concept of the discipline? I thought that all nurses must study cuidado, and with these statements, others arrived, such as caring is not the essence of nursing knowledge, a garbage collector cares of doing well their job, and so forth. This made me think, if nursing is not cuidado, so what is nursing? What had I studied for so many years? I proposed to myself to show that hidden reality, focusing my research on Colombia and real women in my country. But that decision brought other challenges because I was forbidden to use literature written in any language other than English in one of the assignments. This prevented me from developing my class project on one topic concerning my country. This was a very colonial, discriminative, and violent measure hidden as what is best for you. The centralization of nursing knowledge brings up the postmodern idea of the otherness, being the theoretical development made by theories outside the US or Europe a dismembered knowledge, forcing the knowledge developed outside the Anglo-Saxon academy to be constructed as the others. Therefore, the scholarly construction with their communities, processes, and cultures is dismantled and denied by the scholars in the core of nursing. These epistemic perspectives conducted by example by nurses from Latin America must study themselves as the others, as a branch, as hierarchically less important academic detachment. It is at this point where decolonization becomes a colonizing instrument using by new power groups instead of co-construct a joint epistemology of nursing, in which most of nursing scholars, even in Latin America, follows the line of the Anglocentric thought, framing their thoughts by the modernity from the States and Europe, and are unaware of or misunderstand or scorn their own disciplinary nursing knowledge. This has been embedded in our own nursing identity, generating an oppression in the inside of nursing and more violently towards those outside of the white English-speaking academy. This reality that cannot be denied, in which healthcare research is about nursing research, brings to my mind a moment in which a professor tried to embed a new generation of scholars with their wisdom by saying, don't go to other disciplines talking about nursing theories that no one knows. If you want to be in the same table, you need to speak their language. Or others saying, I think that what nursing contributes to interdisciplinarity is the concept of holism. One thing is to speak their language, another deny our own knowledge and heritage, or even reduce it to a single concept of holism. This denial of our own increases the rejection of the external nursing, and even more by using English as a tool of epistemological power. Rethinking, dignifying, and putting the knowledge developed in other languages, both theoretical and practical, at the same level of the historical white and Anglo-Saxon theories of nursing requires of a constant reflection of inner colonialism, generating an identity turn, ceasing to deny the other, the minoritized, in order to exist and survive. In my own experience, until I didn't share in English a small portion of my own Latin American nursing knowledge, this was not recognized. And still today, there are those who dare to tell us that cuidado is not the essence of nursing. Decolonizing epistemologically, scientifically, and culturally is a revolution that as a nursologist we must make. There is so much that we talk about social justice and emancipation of nursing. And today in 2021, there is still no real interest in a disciplinary term that dignifies nursing and our history, ceasing to be a colony of a culture and a foreign epistemology that we believe is ours and is false. It is not ours. It is that of other disciplines. Decolonizing the academy will mean making it disappear. However, we can think of it in a more critical way, since decolonization is more than deconstruction. It is a paradigm shift that recognizes other epistemologies. For example, the epistemologies from the South, rooted in cuidado, and other epistemologies outside the academy. More recently, I had faced imposition of anonymity over Afro-descendant and indigenous parteras tradicionales in my country who I develop or research with. And now that statues and monuments are falling, an editor of a renowned academic journal tried to force me to colonize the indigenous and Afro-descendant parteras tradicionales by taking their names and faces out, going against indigenous ethics and their explicit request. They want to be recognized, and a dominant society still excludes them by denying their rights and agency. This context therefore obliges the academic community to rethink the modalities of knowledge construction, no longer about, but rather with, moving towards a true process of decolonization. We cannot deny our history. Instead, we shall acknowledge it. The world that wants to project itself into the future must rely on the past, because if it lives only in the present, it perishes with it. To forge our own theory of nursing and trace its diverse roots, I believe that the purest identity of nursing is the source of stagnation and the critical state of the disciplinary nursing knowledge. These realities in which we are called to recognize other nurses with their epistemologies, ontologies, paths, and meanings have made us love the diversity that is waiting for us tomorrow. So please don't minimize us, don't erase us, hear us, because we exist and we are here, and say our names. Rosa González, Andrés Fernández, Caterina Flores de Guerrero, María Josefa Esperanza, Teresa Urrea, Leonor Villegas, María Sada, Clotilde García, Eva Carrillo de García, Esther Díaz, Irma Aguilar, Hortensia Laguna, Idaura Murillo, Miriam González, Silvia Méndez, Richard Carmona, María Domínguez, Eloísa Tamés, Nelly Garzón Alarcón, Inés Durana de Samper, Elvira Dávila Ortiz, María Currea, María Mercedes Durán de Villalobos, Edilma Gutiérrez de Reales, Concepción Arenal, Sofía Pincheira, María Luisa Aguirre, Margarita Núñez y Núñez, Martina Guevara, Pellegrina Sarda y Sarda, and so much more. Thank you so much for listening.
Thank you, thank you, thank you, thank you. I would like to introduce the final speaker of the evening. Dr. Bukola Salami, would you like to share your screen, please?
Can you see my screen?
Yes.
Can you
Yes.
Okay.
Yes.
Sorry about that. Today I'll be talking about, thanks for inviting me to talk today. I will be talking about decolonizing research with Black youth on mental health, and I'll be talking from a research perspective. So I respectfully acknowledge I am located, and I believe it's also possible that there is one other person located in, no, she's not located in the same territory. I'm located in Treaty 6 territory, a traditional gathering place of indigenous people, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Anishinaabe, Inuit, and other peoples whose history, languages, and culture continue to enrich our vibrant community. I acknowledge the ancestors, teaching, medicine, languages of this land that continue to nourish my spirit and positively impact my life. And I also acknowledge that I am located on stolen land, and I appreciate the opportunity to be on this land. So in terms of my personality, I was born in Nigeria, and of course the name Nigeria is even colonial in its sense. It means the word Niger area. It's an English word. Migrated to Canada in 1997. I did my undergrad and graduate studies at the University of Windsor and University of Toronto, and I'm currently Associate Professor of Nursing at the University of Alberta, and also Director of Intersection of Gender Signature Area, which is a signature area that is across the university. So I will talk about a research project that I did with this youth, and there's one youth that is now in the picture. She's right here. I don't know if you can see my mouse. They were co-researchers on this research process. This is the final day of the research project, where they presented their research to diverse stakeholders in Canada. So why is this important? It's important because of the anti-racism that Black Canadians continue to experience in Canada. And this is reflected in the United Nations Working Group of Experts on People of African Descent who came to Canada. And they indicated that Canada's history of enslavement, racial segregation, and marginalization of African Canadians has left a legacy of anti-Black racism and had a deleterious impact on African descent, which must be addressed in partnership with affected communities. A misconception is often that there was no slavery in Canada. Not true. There were Black slaves in Canada, and there were also Indigenous slaves in Canada. And even up to around the year 1910, there was a policy implemented in Canada to burn people who were of races that could not survive the climate and conditions of Canada. So it was a policy that was implemented specifically to ban non-white people from being able to migrate to Canada. And it was in place from around 1910 to around 1960s. My work is really influenced, and I took a pivotal turn during my doctoral work after I read the work of Gayatri Spivak. She's a post-colonial researcher. And of course, I know there's been debate related to post-colonial, anti-colonial methods. And because Spivak questions, whether the subaltern can speak. And she describes the subaltern as the position without identity, where the social lines of mobility do not permit the formation of recognizable basis of action. Our article was more about widows in India, and also about issues related to voice and challenging Marxist notion that, since the subaltern have that the subaltern cannot speak for themselves. So one of my goals has always been issues of addressing voice and ensuring representation in my research process. I am also very much, I am very much, my perspective very much in this, in terms of, and I'll read this quote. Well, you get the idea of the interrelation between politics of identity and epistemology. You can certainly be a Maori and an anthropologist, and by being an anthropologist, suppress the fact that you're Maori, or Black Caribbean, or Mayan, or in my case, I can suppress the fact that I'm African. Or you can choose the decolonial option, engage in knowledge making to advance the Maori cause rather than to advance the discipline. Why would someone be interested in advancing the discipline if not for either alienation or self-interest? If you engage in the decolonial option and put anthropology at your service like Smith does, then you engage in ship-making the geography of reason, in unveiling and enacting geopolitics and body politics of knowledge. And, I have had, instances where I've had to choose between advancing the discipline and advancing African Canadians in Canada, and I consistently choose to advance. So of course, one of those things is sometimes my publications are a little late. So for example, what's on my timeline, trending on my timeline now, is a publication we just had on mental health of Black youths. But that publication has actually made changes to policy and practices before it got published, because of course my priority was to advance the interest rather than scholarly knowledge. So some of the attributes of decolonial research includes voice and representation. And I often use participatory approach in my research, addressing, and it's important within that to address underlying inequities in the research process, that we don't all start with the same, on the same footing, and there are the inequities. And I mean, my position, and even though I'm African, there's also positioning in terms of my class status, that really, I have to always reflect on to ensure that I address issues related to power imbalance. And to decenter the researcher, and positionality and critical flexibility is quite important. That I am not, I don't have the knowledge. The youths that I work with have way more knowledge than I do. And this became even much more clearer to me as I continued the research process. And an emancipatory agenda. So I have an activist stance, and I engage in terms of ensuring that my research is actually useful for the communities that I serve. So the research started when I was a board member of Africa Center, which is a nonprofit organization here in the province of Alberta. And at that time, I met with 8 Black youths. At that time, I was on the board. I heard that the youth were struggling in terms of being able to achieve some of the things they want to achieve. So I asked to meet with them, and my question is, how can I be of help to you? And at that meeting, they wanted to focus on mental health. They wanted an participatory approach. And the youth were very, very particular. And they told me, we don't want involvement. We want to actually lead this research project. And they wanted intersectionality and decolonization. They wanted to focus on their African, Black, and Caribbean experience. And if you know, even the fact that, some of us, indicate we are Black, some of us indicate we are Black, African, and some indicate we are Caribbean, are all elements of the colonialization process that has got us to this stage. And the need to build capacity and the willingness to contribute to the project. So, in terms of addressing issues related to inequities, the youths engaged in the research project fully. They were, some of them, I hired them as research assistants, some that didn't have really much time, and it was, so they were paid in terms of how many hours they spent attending meetings. They revised the interview guide once it was developed. They interviewed some participants. About half to 70% of participants were interviewed by the youth. They organized and led conversation cafes. So they had their own WhatsApp group, and they would organize, events. They would have a meeting, and then they would come to me, and I'll help them in terms of refining their idea. They developed initial conversation cafe guides, and it was so rich because they were at the forefront of developing the questions, and facilitated participant recruitment. They did analysis of the data. I taught them analysis, and they were also co-authors on reports. So as you see, they have given a few presentations. They led the stakeholder engagement day, the stakeholder presentation day. I didn't present at all on that day. They did all the presentation, and also their co-authors on publications. So in terms of capacity building, we had 4-hour training on qualitative research and research ethics. They completed research ethics model. A couple attended one-day training on qualitative data analysis software in vivo. They had close mentoring of 2 doctoral students, at least 1 meeting with me before each conversation cafe. And what we did, for this project, we had to address the mental health, or to bring to light issues related to mental health of Black youths. We organized a series of conversation cafes, which were a forum for people to actually share ideas and also germinate and develop new knowledge together. And we capitalized on their strengths. Some of the challenges we have was power relations. And, of course, there's intersection related to not just my race. And, I think that was positive for the research process, but also in terms of my age, especially in a community where respect is very, very important in the African culture. And also in terms of my class status. And a way for us to bridge that was to have research assistants that were doctoral students and could help in terms of bridging that. Issues related to time, flexibility, reconciling gaps between academic priorities and also community priorities, and I often always choose community priorities, funding limitations and priorities, and also issues related to data security and confidentiality. And the way that we address the issue of data security and confidentiality, because it's a small committee and youths may know each other, is that we had separate files, so the youths only had access to the files that they collected data on, and not to all the files. But there was just one or two of the youths that had access to all the files because they analyzed all the data together. So here are some of the rewards, and this is, the paper that we published. The first paper just got published yesterday, and I tweeted about the paper, and that's the youths that said we're excited that our paper got published, and we are thankful to Dr. Salami. And that's the Africa Center, the organization I collaborated with that retweeted that. But before the paper got published, this research has led to the creation of a mental health clinic. So the conversation cafes and discussion, the last conversation cafes, the youth wanted it to be about policy implications and practice implications. And the youth took their colleagues through the creation of a mental health clinic, was part of the discussion. And they took the notes from that mental health clinic and gave it to the board, to the director of Africa Center, who then used it to apply for funding in collaboration with Alberta, Black Therapist Network of Alberta, to create a mental health clinic for the youths. It's also been translated to research, so to policy. So I was invited to speak to the Prime Minister of Canada, and I presented some of this work to him, and it's led to major changes in Canada. Recruited more participants than we had planned. We had rich data on mental health, and youth led and delivered the results to stakeholders, and capacity building and learning experience. But I think for me, I may be self-centered, it was really personally fulfilling that I was not just producing knowledge, but I was actually contributing to the lives of Black youth and making tangible contribution. And sorry, I may be late, but that's about it.
Thank you. Thank you. There were questions about whether you might be able to place your publication in the chat, a link to where that might be. And if
I will do that.
That would be, and if any of the other speakers would also like to put anything in the chat in terms of a link or where to go to. And if you don't have the ability to do that at this moment, I just wanted to let everybody know this is being recorded. The recording will be shared with all of you, and I can also disseminate other information if the speakers bring them to me. So we will have multiple resources for everyone. So thank you so much. This was absolutely breathtaking. I've been busy trying to manage times, etc. I know that there were some questions. I wanted to say that everybody mentioned that they could stay after our formal 4:30 ending. So thank you to everybody for staying. And I'll let Peggy and Marlaine lead off with the questions part of this panel.
I also was thinking that we could have the questions that are in Q&A in particular addressed by the panelists after this meeting, and we could post it on nursology.net as a blog post very soon with panelists' responses to the questions so that people who need to leave don't have to miss what we're doing. If panelists are willing to see those questions afterwards and just give whatever responses you want, we'd be glad to do that. So basically we had a couple of questions, and I'm going to try to keep this pretty brief and so that we can use the kind of more written thing to really get into the depth and not disappoint or disregard anybody. But there were a couple of questions related to nursing education and how we can decolonize nursing education. So I would like to invite anybody who on the panel who would like to say a few words about that. to do so.
Peggy, what was the question?
Ways to decolonize nursing education.
I can provide some thoughts on that. Nursing education, though, is a beast. People are going to get upset with me for saying this, but it's the root of all evil in nursing, because we have people who come in students who come in are so fresh, they're ready to learn. And some of them get that nurturing and others just constantly get beat down. And I have to say something about this. We have to look at our standards, because people always talk about, oh, we have to have standards, or, we can't just let anybody in. But yet there's students who come in and have who are trying to learn and adjust and figure out who they are, and they get support. And then we have students who come in who are honor students in their high school. They're strong, and then they're constantly being criticized. If we don't get them in the classroom, we're going to get them in clinical. And also, I'm just throwing around a couple things because it's so complex, but we have to question the systems that currently exist. If the only person you're talking about is Florence Nightingale, that's a problem. If you're having a class on med-surg and you don't even talk about how do you find out who your patients are? Yeah, I can't tell you how many students I see as seniors and all they focus on are medications. They don't know how to find out about someone's culture, their beliefs. I'm like, your textbooks tells you this person needs to take insulin at this time, but what if they don't have insulin? What if they don't believe in insulin? What if they don't even understand what you're telling them? So students need to know how to think critically about that. We can't leave that out. And I always feel like when we add things about just diverse cultures, diverse beliefs, we talk about the structural issues that exist in our healthcare system, that everyone, not just people of color, but everyone benefits. But it's just that when it comes to people of color, we're more likely to die. We're more likely to get subpar care. We're more likely to be ignored when we say we have pain. So there's a lot of damage that's done to us. But as nursing leaders, I feel like if you're an educator, you got to look at your textbooks. Don't just tell someone to read chapter 2, and then chapter 2 tells you that this is my maternity book, but I use this as a teaching technique. It says that Black women exaggerate their pain. Asian women, they're very quiet, so they'll have a lot of pain before they ask for help. I have a friend who's Asian. She's like, I don't know that woman. I don't know that woman. But anyways, that's what the textbook says. And the students read that as law, especially if you don't disrupt it. So I actually did contact the publisher. Allegedly, the new edition is going to change, but I still use it right now. I tell my students, you see that section, that table that talks about how cultures talk about race? Take those pages and rip them up. Because if we don't disrupt it, they're going to believe that that's true. And then that's what they're going to believe to these patients that they probably never had contact with in their lives. But we just have to keep challenging everything from admissions criteria, progression criteria, even how exams are done. Some of the exams use language that I don't even know. So how is a sophomore nursing student supposed to understand? So anyways, we just have to challenge it at every single angle. And I notice the more that I speak up and challenge it, and this is the last thing I'll say, the more that it starts to be dismantled, because they'll say, oh, that's nursing, that's what we need to do. Well, can you tell me in the nursing literature where it says that if I know biochem, that I'm going to be a good nurse? Show me that. So that's when they can't produce the evidence. They say, oh, we did that research study. When? Oh, when so-and-so was here. That was 13 years ago. And I don't even see it published. So anyways, when we start to question it, is one way to just start to break things down. So no longer do I sit silent when something is ridiculous. So we all have to continue to do that, regardless of where we sit in nursing education.
Bucola? Oh, you're muted, Bucola.
So decolonizing nursing education, I think we need to think about the diversity of the profession, and also think about not just in terms of diversity, but also inclusion. and equity issues within the profession. So one thing I hear is, we can't recruit because we don't have, people in the profession. We don't have Black or Indigenous nurses to recruit. And sometimes we also talk about, well, they don't have enough publications. But then there's also a colonial route that actually structures how much people are able to publish. A lot of BIPOC and Indigenous researchers, they're engaged in more community work that is often not seen or not acknowledged, or they're engaged in knowledge, other areas related to knowledge production that is often not acknowledged. So we need to actually look at knowledge production and look at people's CV through a decolonial lens. The other thing is representation matters. And sometimes that is very, very important in terms of ensuring decolonization, and also thinking and challenging what is knowledge exactly? Who produces it? How is it produced? And how is it being used? And there may be errors across all segments of the knowledge production and use utilization cycle. And ensuring that anti-racism and also capitalizing on the agency and strengths of BIPOC researchers, with also some caution, because you can't over reliance. And I think we need to really think much more from an anti-racist lens in terms of challenging some of the hegemonic practices that we have within the profession.
Jennifer.
I also think that it's really important that we have policies in place where students are safe to be able to disclose if they're experiencing microaggressions in the clinical setting, or even from faculty. So many universities and colleges don't have that in place. And I think it's like now on people's radars, but it's so much more important in nursing because that's going to be a barrier for a lot of students if they are experiencing microaggressions and experience racist behavior from faculty. Like how will that impact them in their future lives as nurses? So I think that as educators, we need to be proactive in making sure we have policies in place and safe places for students to be able to share and disclose.
Lucy. And then also stop asking students of color to represent every issue that is non-white, so every time there's something being discussed, pointing the microphone at them. Let's do our own work. We're the educators. We're supposed to be understanding this. And yeah, definitely creating safe spaces for ethnic minority students, because they're navigating constantly a white space, and that is unhealthy and harmful to them. So being really conscious of that all the time is important.
I recently asked some students about how to ensure anti-racism, and what they told me is this whole idea about it's a class, you're the only Black person in the class, and feeling like you're now so hyper-visible. You're invisible, but at the same time, you're very, very, and a lot of Black students, sometimes they will cluster in the same class just to challenge that. It's a resistance against being, so hyper-visible. And, I think it relates to what Dr. Lucy said in terms of, having to always be the one to defend everyone of your own race. There's one Black person there. 10,000 Black people have done good things, and one Black person has, not done something that is too great. And all of a sudden, everything is based on the one Black person, not the 10,000 that have done great stuff. And I think we need to really, really shift the gaze.
Lisa.
Yeah, I was just gonna contribute there too. I think when we're talking about epistemic injustices, right, is that we really, when you think about that hard work and hard in terms of heart, that's really hard for individuals to do. And so we really need to support this gazing of our shift from the individual to the systems, right, to policy. If we want faculty and allies to do this work, we need to support that work. The system has got to change before we can, you know, hold individual people accountable. We have to create those tools that serve that diversity, because, you know, everybody says it's not there. We don't have the ability to have spaces to critically think and unpack what we hear and what we read in textbooks and our own individual experiences. And I think, you know, I'm excited for nursing, because I think we have arrived at a time that we can come together here and share our collective vision on how do we, you know, really address that the epistemic appropriation that you've all alluded to, right? We call on our students, you know, there's resources here. At the end of the day, you know, we have to address capitalism and neoliberalism and all of those big concepts that, you know, don't address the people that we serve. Nursing is a people practice, and until, you know, sometimes faculty, we get caught up in our concepts, right? Our concept-based curriculum. All those concepts live somewhere. You know, it's that contextual reality that we're devoid of, I think, in you know, that's that hard work and that hard work. You know, why aren't we accountable to the local communities we serve, whether they're in the municipality or within the clinic right down next to me, right? We're utilizing those services. And yeah, okay, thank you. So important.
Yes.
Yeah.
Peggy, you were going to say something?
I was just going to say that we probably need to put the other Q&As onto the web, but we will do that.
Yeah, I will thank you for that. I will share a wealth of resources to all the registrants when they will get an email, and the link will be provided to the video. I will save this chat, which has a multiplicity of resources. Thanks to everyone who's posted. Thanks to the speakers. I now have I have my first class already ready to go. I'm just going to press play on Monday and then see what generates in terms of dialogue. So thank you all. Thank you, Peggy. Thank you, Marlaine, for the organization of this event. I want to wish everybody as safe and wonderful as the rest of the fall quarter in terms of we're all educators as we can. Thank you, and let's already be thinking about the next one.
Thank you, Miriam.
Thank you. Thank you all.